Dr. Hilary Onyiuke, Associate Professor of Surgery and Chief of Neurosurgery for the John Dempsey Hospital of the University of Connecticut Health Center, is here to speak with us about neurologic examination. Welcome.
Welcome, Dr. Schneiderman. Thanks for having me here.
Oh, it's a pleasure. And as you know, for non-neurologist, non-neurosurgeon trainees and practitioners, the neurologic examination is often the subject of great terror. We've asked you to advise us on your technique and to demonstrate it, and I'd also like to ask you several questions, if I may. Another trouble that we have is understanding the counterintuitive phenomenon that a lower motor neuron lesion of the seventh nerve produces a more extensive paralysis than an upper motor. Could you comment, please?
I think it's because of the bilateral representation of the facial nucleus on the forehead frontalis muscle that makes it look as if it's less of a deficit, because you then have only a lower quadrant weakness, whereas in the peripheral nerve, it's the whole one side, so it will look as if the deficit is in fact more, but we know that in fact the reverse is probably more disabling.
And finally, if I could ask, we've talked about fundoscopic and other portions of this DVD. Traditionally, we film that with the ambient light high so that the camera can show. But in fact, is it important to lower the room lights?
For the fundoscopy? I think it really depends on the expertise of the examiner, because over the years I've learned to do it with the pupils very constricted and still see it, but there are those who like to have the pupils dilated. In fact, they go ahead and dilate the pupil in order to do a straightforward fundoscopy. So I think for somebody who is still learning, probably keep the lights down so that the pupils will widen, but for somebody who is used to it, it really doesn't matter.
Thank you so much. I'm looking forward to watching your examination.
Thank you very much, Dr. Schneiderman. Good morning. Nice to see you. Please have a seat. My name is Hilary Onyiuke. I'm a neurosurgeon. What's your name?
Sherry Cohen.
Sherry, I'm here to see you mostly really for consultation and also to examine you for the issues that we're about to discuss. We've already taken the history, which you have told me, and what I'm going to do now is to confirm the parts of the history on the examination in order to formulate what the problem may be. Tell me, what's the date today?
September 11th, 2002.
Do you know the month?
September.
September, the year?
2002.
Very good. Do you remember what you had for breakfast today?
Yes. Grape nuts and milk.
Okay.
Coffee.
And what's the date of your mother's birthday?
December 9th.
Very good. Okay, I'm going to do some cranial nerve examination. In other words, I'm actually going to look at the cranial nerves as they come up from the head. It's going to really go from your eyes all the way down to, your body to your feet. Okay. The first thing that I usually would do is actually your sense of smell. Do you smell your food usually? Can you smell your food?
I have a good sense of smell.
You have a good sense of smell. Okay, very good. The next thing I'm going to do is that I'm going to check your pupillary reaction. That would be the second cranial nerve. Okay, so we would look at your pupil, is reacting, look at the other side, see whether it's reacting. And then I'm going to do what you call the flashing light test, swinging from one eye to the other to determine whether you have Marcus gun pupil, which is really a test of an optic nerve problem, which you don't. Your pupils are reacting very nicely. They are equal at 3 millimeters and reacting. And the other thing that goes with the pupil, sometimes I look to see whether your eyelid is down. You don't have any ptosis, and if you actually look up, okay, you have full palpebral eyelid opening. The other thing that I like to do is that I want to check your visual field, okay? And I usually would do that just standing in front of you. And what I'm going to do is that I'm going to have you cover one eye, okay? And I'm going to cover. Basically, we're testing one. You have to assume that my visual field is normal because this is a mutual thing, okay? So if you cover, and I'm going to cover one, okay? And I'm going to you tell me when you first see the finger move. And you just point to the finger that is moving, okay? Okay.
Both of them.
Okay. Okay, now let's close the other one. I'm going to close it, and then we're going to do the same, okay?
Both of them.
Good.
I see this.
Next, I'm going to look at your fundus. Okay, the fundus is the optic nerve as it's actually leaving the retina, and I do that by using the ophthalmoscope. Okay, and I'm going to shine light. All I'm going to do is just have you look at fix at an object on the wall. Okay, and then I'm going to come. Usually, this you can also use. If you could just fix, yeah. This you could also do by when you shine the light should actually give you the pupillary reflex and see where there's also a red reflex on the eye, on the pupil. And once I do that, then I will start to approach the eye. Okay, and then right there, I'll see the fundus. Now, usually I would do it on both eyes. There's a situation where you can actually have papilledema in one eye and optic atrophy on the other side, and we actually call that Foster-Kennedy syndrome. And it's not very common, but don't be fooled by the fact that you just look at one optic nerve and think that the other one will be the same. The last part that I will do will be to check your visual acuity. Okay, normally there's a chart on the wall that is much bigger, but for crude testing, I put this about 2 feet, and normally we'll just have you read off it. Now, I know you wear glasses, usually I'll do with a corrected vision. So I'm sure you may. Can you read the first 2 words? For 2 letters.
S and H.
Perfect. You're fine. All right. So having done the second cranial nerve, now the next to do will be the third, fourth, and the sixth, which actually controls the extraocular muscles of the eye. And the way I do that is that I'll still stand in front of the patient. Usually it's a conjugate. You're checking both eyes at the same time because they move conjugately. So I usually will put a finger on keeping your head steady. Do you see my finger?
Yes.
Okay, and it's sharp, and you have one, or you just see one, correct?
One finger.
Okay, throughout the time that you're going to be moving to follow the finger, I'm also going to find out whether you see 1 finger or 2 fingers, because if you see 2, then that means that there's double vision. And also, I need to know whether the objects are horizontal to one another or whether they are stepped off in an oblique fashion. That would tell me the cranial nerve that may be involved. So we'd go on by saying, just look at my finger. Okay, and just follow the movement of the finger without moving your head all through. And at the same time, I'm checking the eye movement. I'm also checking for nystagmus to see whether the eye is actually, there's a nystagmus to the eyes, up and down. And then we'll look down and out, and then up and out, and up and out. At this point, she has full external ocular movement without any nystagmus, and she did not have any double vision, which means that all those muscles are working. By implication, the oculomotor, the trochlear, and the abducens nerves are working. Next, we'll now go on to the 7th cranial nerve, which is the nerve of facial expression. One of the things I start off by doing, again, is that I tell you to close your eyes tight. Okay, that's the orbicularis oris, which is mediated by the 7th. If you open your eyes, and then I'm going to have you look up. You're going to furrow. You see how the forehead muscle, the frontalis muscle, is furrowed. That tells me that both, at least the upper motor neuron part is working. However, in also doing that, I need you to give me a smile. Okay, she has good symmetry of her smile, and the nasolabial fold here is symmetrical. And can you blow out your cheek? Okay, the buccalis muscle is intact and is blow out against resistance and is tense. It does not collapse. Throughout our interaction, she has been listening. She has been responding to questions, which tells me that she doesn't have any form of hearing loss. Now, also understand that if she has only hearing on one side, she probably would be interacting to the same degree. So normally what I would do is that I would whisper.
Sherry.
Okay, but sometimes I also interfere that by putting a piece of paper to mask the background or to increase the background noise on the other side to actually find out the sensitivity.
Sherry.
Okay, so I usually would do this on both sides. Using a tuning fork to determine the Rine, R-I-N-E test, and the Weber test, and that is to differentiate bone conduction, people who have conductive hearing loss, and sensory neural hearing loss. Normally what we'll do is that for the Rine, we'll tap the tuning fork and we'll place it on the mastoid process, which is the bony part behind the ear, and we'll continue to find out time she feels the vibration, and once she stops feeling the vibration, and then I place it against the ear to see whether she will now hear the vibrations. And if that is normal, then air conduction will be better than bone conduction in a normal person. With conductive hearing loss, it will be the other way around. The other part will be also using the same tuning fork is the Weber, is to put it right on the vertex to see whether she lateralizes the sound to either side. And in this case, if you have conductive, they'll hear the conduction more to the abnormal side. There are two components to the nerve, the cochlear and the vestibular. The vestibular portion is the portion that is for balance. And one of it I've already tested, which is the nystagmus, when I did the eye signs. Now, the other parts I have to, we need to do now. There are several parts of it. The first one is actually the Romberg's test, which can be a proprioception issue, or it could also be vestibular. And I might as well test it now. If you can just stand up for me, and you put your feet together. Okay, usually the sensation from the ground actually tells you, with the vestibular system, would tell the brain where the body parts are in space. So in this case, you have to remove, because with your eye, you can actually focus to try and tell you, to try and maintain your balance. So in this case, we have to remove the sight aspect to it. So I'll have you close your eyes, okay? And I usually just have them stand. Now, if it's abnormal, they are going to start to sway because they cannot cue where their body parts are in space. And in fact, she's perfectly rigid. That's perfect. Thank you. If I'll have you sit back again. Now, we now move on to the 9 and 10, which is the glossopharyngeal and the vagus nerve. Now, that's usually done by actually looking into the mouth. When you open up your mouth, actually, I need you to open up your mouth. That is correct. What I do is, first of all, shine the light, and I look for and you say, ah. Ah. When you do that, the uvula, which is the structure right at the back of the mouth, should be midline. That is mostly controlled, really, by the vagus. Now, to do the gag reflex, which actually represents the sensory part for the glossopharyngeal, is the gag that everybody knows, is that you put this to the back of the throat, and she will have a gag. Now, in fact, she doesn't have an increased gag in the sense that there are some people who are incredibly sensitive to it. She does have a gag, and the uvula went up. So usually we'll do it on both sides. Okay, the other part to the vagus nerve testing is actually the voice. We can document already that her voice is good. She doesn't have any hoarseness of voice, but if she did have hoarseness of voice, then we have to do an indirect laryngoscopy by having a reflecting mirror inside the mouth to see the vocal cords, to see which one is not moving. Okay, so the last two that we need to perform is the accessory nerve, which is nerve number 11. And mostly I use that for shoulders. So if I can have you shrug up, that's correct. So that's testing the trapezius muscle, actually against resistance. If you can hold it, don't let me push it down. Good. So that's stressing the trapezius. The other muscle to test is the sternocleidomastoid. And what the sternocleidomastoid does is that it actually moves the neck to the opposite side. So what I usually do is to push my hand against resistance, push it. Good. And then push it the other way. Very good. So the sternocleidomastoid is perfectly intact. Then the last thing is the hypoglossal nerve, which actually mediates for the tongue. And usually the tongue should be midline. When one of the nerves are abnormal, it will deviate to the abnormal side. So if I can have you stick out your tongue for me, that's perfectly midline. The other thing you look at while looking at the tongue is to see whether there's any atrophy, whether there's any fasciculations of the muscle, because that would tell you whether this is a lower motor neuron peripheral nerve hypoglossal, and she doesn't have it. And the last thing is furrowing of the tongue, and this is perfectly normal. Very good. Having completed the cranial nerve examinations, mental status examination and the cranial nerve, now we can also do what I call the long tract signs, looking at some of the pyramidal system, especially if I have someone presenting with an intracranial lesion. One of the first things I do is actually to determine whether the patient has a drift, what we call a pronator drift. And what you're going to do is to put your hands out in the air for me like that, okay? And then you close your eyes. Okay, the hand does not drift. It stays horizontal as I've placed it. If she had a pronator drift, it will start to pronate like that, and then it will start to fall. And that, to me, is an indication of a pyramidal tract, corticospinal tract lesion. Thank you very much. Now, motor strength, that also checks motor strength in the upper extremity anyway. But individual motor strength we can do. But the important thing really is that whichever muscle group you're looking at, you want to see whether the muscle bulk is good, that there's no evidence of atrophy. You check to see that there's no fasciculations or twitching, which indicates more of a peripheral nerve problem, and she doesn't have. And then for usual strength for the upper extremity, I do very easy, fast exam. I check the deltoid. If you hold it up that way, hold it there, don't push it down, that's deltoid. Then that's the biceps against resistance on both sides. Then the brachioradialis, I do like that, you hold it against resistance. Then the triceps, you actually bend and then you push it, you extend it for me. That's good. That's normal strength. Then the wrist extension, up, if you hold it up, good. And then if you keep it straight, that's the finger extension. And then the last thing is the grasp. Squeeze it for me. Excellent. And the same thing goes for the lower extremity. I usually check, I actually go from distal to proximal. I usually do the dorsiflexion. You hold it against resistance. She holds it. That's the tibialis anterior. Then the extensor hallucis, the extensor hallucis longus. You pull up your toe towards you, over towards you. This is usually more for spine examination. And then the next thing is the hamstring. I want you to dig your foot in there. Don't let me straighten it. That's very good. You do it on both sides. And then the quadriceps. Then you kick against resistance. Excellent. On both sides. And then the next thing I do is actually the hip flexors. If you pull up your knee up, hold it there. Same thing there. Very good. And lastly, I do the adductors. If you pull your knee together, don't let me straighten it. That's excellent. So this really corresponds to muscle groups in the spine. So this will be C5, C6, C5 for the deltoid, C6 for the biceps, C7 for the triceps. Wrist extension is 6-7. Wrist flexion is 6-7. Finger extension is 7-8. Finger flexion is 7-8. And then the adductors, which I didn't do, the intrinsics of the hand. If you hold up your fingers like that, don't let me collapse it. That is actually 8-1, C8-T1. And then the same goes for the lower extremity. The dorsiflexion is actually predominantly L5. The hamstring is predominantly S1. The quadriceps is predominantly L4. So in testing for the reflexes, which will be the next thing to do, is that I'm just going to look. There's certain muscle nerve roots there that corresponds to the reflex center. Usually it's the biceps, the triceps, and the brachioradialis. And in testing for the biceps, which is predominantly C6, this is how I test it. I put a finger into where the tendon really inserts, just before the tendon inserts, and you straighten and you hit it. So you have a contraction. Usually do it on both sides. And then the triceps, it's the same thing. Sometimes you may have to support the hand, but now that she has it on herself, then that's the support. And then you just tap the triceps one, and it extends. The last one is the brachioradialis that I do. I place my finger over the insertion of the brachioradialis and tap it, and it pops up. One of the other ones that you can see in an abnormal reflex is what you call the inverted radial reflex, which is when I tap the fingers. And for people who also have upper motor neuron lesion, it will become exaggerated. Just like you also have abnormal reflexes. Still staying with the upper extremity is the Hoffman sign, which is an abnormal reflex. You keep the finger, the middle finger extended, flexed, and then you tap the last digit, okay, and the IP joint. And if there's an abnormal Hoffman's, the whole hand fingers will contract at the same time, and she does not have that. Then going down to the reflexes in the lower extremity, then we also do the patellar knee reflex. Very good. And then the other one is the ankle, where actually I stretch the hamstring a little bit, and then I tap on the Achilles heel, and she does have a reflex. The last abnormal reflex that you can elicit from the lower extremity is the Babinski response. Well, it's actually called the plantar reflex. The actual abnormal finding is the Babinski sign. There's really nothing called the Babinski response. It's a Babinski sign only when it's abnormal. So it is a plantar response. And the point is that you stroke the sole of the foot and the toe goes down appropriately like she did. If it was abnormal, if it was a Babinski response, what's going to happen is that the toe is going to go up, and it will all the toes will flare up, especially the big toe. So that's also a feature of an upper motor neuron lesion. Now, the sensory test also depends on what aspect of the body that we're talking about. Usually, one of the first things I do for an intracranial problem is actually check to see whether she has a neglect or whether she actually does know that she has sensation on both. And to determine that, I do a simultaneous touching of her hands. So if you have your eyes closed, and actually turn the hand in the supine position, I touch the hand at the same time to determine whether she can actually determine whether I've touched both hands. If she extinguishes, or what you call a neglect, but she'll only remember that I touched only one side. Which side did I touch?
Both.
Both sides. Very good. So that's one of the cortical sensory changes that I check. The other one that I check is that if I have a coin, I'll put the coin in her hand. You can play around with it. What kind of a coin is that? Is that a nickel, dime, or quarter?
A dime.
A dime. That is, in fact, correct. Very good. And for the light touch, what you want to do is to use a small whisk of cotton with your eyes closed. And what I usually do is that I do a sham one, and I tell the patient, "Do you feel anything?" And do you feel me touching you?
No.
No. Okay. Do you feel me touching you?
Yes.
Okay. Do you feel? And I always do it. Now, most times, what I do, if it depends, for a spinal, for examination of the spine, you want to go through the dermatomes C5, C6, C7, C5, C6 to the tongue, C7, C8, and T1 to make sure that the roots are intact. And the same goes for the lower extremity. I usually will just start probably at L4 already, and then touch L4, which comes right up to the front of the leg, L5, which is the lateral side on top of the toe, the dorsal part, and then S1, the lateral aspect of the foot as well as the calf. And that's exactly what I'll do too with the pinprick, L4,
Feel it.
L5,
Feel it.
S1.
Feel it.
Okay. Then finally, the cerebellar testing. You can open your eyes now. It's I do three things: the finger pass pointing, the rapid alternating test, and the heel to toe and test. So what I need you to do is that I'm going to keep my finger in front of you, and I want you to touch the tip of my finger and touch your nose, and I'm going to keep moving my finger, and you're going to move along with that. Okay. Very good. Touch your nose. Keep going. And the whole point that she's always on target, touching my finger. It does not move. It does not waver. Very good. And I'll do it on both sides. The next one is what you call the diadochokinesia, or the rapidly alternating hand movement. So I want you to go like this, very fast. Faster, faster. Very good. And then do with the other hand. Excellent. Then the last one now will be doing the heel to shin test. And that's if I can get you to stand up. Thank you. And yes, if you can just start from there, you go in a straight line. Very good. Usually the police officers know how to do this test very well. Thank you. That determines balance. So basically, that's in a nutshell will be the form of type of examination I'll do in general for any patient who has a neurological problem, understanding that it could be obviously focused more to the area with a little bit more detail. But I think this concludes our neurological examination.